podcast, and I'm here today with the English physiotherapist Tom Jesson. And Thomas, thank you for joining.
Thank you for inviting me, Brian. Thank you.
Tom, could you give a brief bio about yourself and when you graduated and what you've been doing, and then we're gonna talk something about radicular pain, if I don't remember the subject right.
Yeah, that's it. That's like the only thing I know anything about. So I hope that's what we're talking about.
We're going to do a massive talk on radicular pain
then. As you say, I'm a physiotherapist from the north of England, Newcastle in the north of England. I'm a fairly recent graduate. So I trained in my mid-20s and I graduated, I must have been 28, 29. I'm 31 now. So I was watching your interview with Mark Laslett, and I worked out I have 1/25 of the clinical experience of Mark Laslett. So I'll try 25 times harder for this podcast and hopefully make up for that. So I'm a fairly recent graduate, and I've worked in a musculoskeletal outpatients clinic in the northeast of England for most of my brief career. So it was in a really nice little setting, actually. It was in a GP clinic. So we knew the GPs. Most of the referrals would come from the GPs who we knew, and we also got some kind of direct referrals as well. And sort of your pretty standard MSK physio stuff: bad backs, bad knees, and radicular pain. And I've also had 6 months after that in a persistent pain service, which was very different. So the kind of other end of the spectrum, in Lincolnshire in the UK. So a specialist pain service there. Let's see, kind of along the way, I got into this radicular pain thing. I don't know if you want me to explain that a little bit.
I would like to hear your way into that, because if we're working with radicular pain, like most of us, we see it in private practice, and then there's some departments at hospitals, and there's something in the secondary sector as well that sees it. But if we should just refer back to the triaging, we know that there could be tons of patients having it, but really depending on context, how much you see it, I guess.
Yeah. And I think it's maybe, I guess, like all conditions in a way, but maybe even more so for radicular pain. It can present in so many different ways. So when I was in kind of the outpatients clinic, as you can imagine, a good proportion of the patients were just acute onset, and often they hadn't even seen anyone else as well. So they were in that stage where they were like, holy crap, what's happening? This is the worst pain I've ever had. Unable to walk or sit can be really debilitating. And I think that's partly why radicular pain sort of caught my eye early on, because I sort of twigged after a few months, like these patients seem to be, on average, a lot worse than the other patients. Often someone gets arthritis or a bad back, it can kind of come on slowly, but with radicular pain, you do sometimes have that build-up phase, right? But there's also often this phase where it suddenly becomes much worse.
Yeah.
And that really kind of puts people in a state of confusion, I think. So that's why it caught my eye originally. And then when I was in the persistent pain service, you get to see the other end of it, where people kind of have seen 5, 10 more clinicians, and tried 5 or 10 different things. And often when you chat to them, they're an expert in the health service, but they don't really know anything about their condition, and they've not really got anywhere either.
Yeah.
So kind of joining up those two things is something I'm quite keen on doing. Trying to make sure that people get the best treatment early on seems quite important to me.
Yeah, because that actually leads me to something I prepared for later on. But as you said it, and the recent paper by Osterlo, I think it came out this year, that we tend to say, like, as you said, the acute non-radicular patients, they normally have a good history, but these people seems to be different, right? Just takes longer. They're not more or less free of symptoms after 6 to 8 weeks, as a usual back pain is. These people seem to have something that's more persistent, it's more prolonged. It doesn't seem to be that self-limiting all the time, which his paper also suggested that I think it was 50 or 55% after a year, still reporting quite a substantial amount of disability and pain.
Yeah, and so that stat comes, by the sound of that stat, comes from one of the Keel group in England, the Atlas trial, and that was patients. They took on patients at all stages of the journey. So that wasn't like a kind of longitudinal study measuring from start to finish type of thing. That was just some patients who came in already had like 3-5 years of pain.
Yeah.
So that probably is that maybe slightly pessimistic estimate, we hope, because it's or we should at least clarify that sort of 55% figure applies to a very mixed bunch of patients. But even so, I think, it's a really important point to make that we don't know how many people, let's say a group of 100 people who've had radicular pain for 1 week, we don't know how many people of them will get better, but we do know from the data that a significant number won't. If I was going to guess, and I'd emphasize it as a guess, maybe about a third of people will probably have ongoing trouble with pain. So that's like again, we feel like we're so maybe skipping ahead of how you wanted to in the podcast, but it's a really important issue to me of how we handle that early on.
Yeah, it is. No, I think we can stick to that one, Tom, because it falls back to it doesn't matter on this podcast which way we flip it. We just need to judge subjects. That's important, and I really think this is, because it comes back to the more or less generic approach, and I know you've seen in what I've talked to other people about that this generic approach might be too optimistic when we're talking this group of patients actually. And by just saying that prognosis is good, where we know it's less good for these people, and I know you touched about it yourself because you talk to patients as well. And I mean, I've had radicular pain. It didn't go away after 6 to 8 weeks. Trust me on that one. I mean, so if we should predict prognosis, we should try to do with most of our patients as good as possible, of course. I think we're missing an important issue by just saying that this is the same as having an acute onset of back pain. I mean, that's at least that's my perspective on it.
Yeah, and I think if we would probably unpack that and say that the problem seems to come. I should really credit, and I always want to kind of mention other people, because as I say, I'm not sort of a PhD. I haven't gone out and done the research myself, so it's important for me to credit other people. And Tina Price, who is a blogger.
You mentioned her. I think that's the one you mentioned. Yeah,
a blogger with sciatica, a writer, and she writes at livingwellpain.com. I think it's .com, not .net, but we can put it up in the notes. And she was kind of the first person to call my attention to this, which I kind of noticed that, and then she kind of called my attention to it and helped me to work it out, that a lot of people with sciatica have this experience of going to different clinicians, as we say, different physio, the doctor, and they get told, oh, don't worry, it's self-limiting, it just gets better. 6 to 8 weeks, it'll get better. And it's just not true, right? Yeah. So those people probably feel great when they're first told that, or at least a little bit more reassured. Yeah. But once you get to that 6 to 8 weeks, having spoken to lots of different patients, that's the time when they think, well, it's not getting better. What's happening? Yeah. Is there something more serious going on? Is my physiotherapist an idiot? Is there something wrong with me? Am I doing the wrong thing? The good reality. And that's when maybe the journey for a lot of patients suddenly becomes a rocky road and they start to have trouble. Because we know from the qualitative literature, one of the particular problems for people with sciatica is they can get stuck with their life on hold. That's a phrase from the Ryan and Roberts paper.
Okay. Yeah.
Stuck with their life on hold, with this sense that they were okay few weeks ago. They're in pain now, but they're going to be okay again in a few weeks. You know, and there's a Ryan Roberts paper. There's another one, and they're speaking to people who are a year into the journey, 2 years into the journey, and they still think that this is just going to get better, and I'll wait till it gets better before I go back to work, or before I go back to the gym, or before I go swimming. So I think often physios, when we're too optimistic with telling people that they will get better, we actually feed into that process of not allowing people to come to terms with the fact that their life has actually changed now, or that at the very least it's going to take much longer and they shouldn't be waiting. You know?
Yeah. So the implication of our messages, both too positive and too negative, will definitely have an impact.
And it's difficult because we want to give people, you know, positive. We want to give people hope. We want to give them positive expectations as well, because there is this idea, probably some truth to it, that people with positive expectations get better because, I don't know, mind-body connection, or maybe they just get out there a bit more and do more stuff.
So I haven't got the answer, but you're right.
We don't want to kind of obviously be too pessimistic. So I feel like we've almost stumbled on one of the most difficult issues in the whole topic here straight away, which is like, how do you navigate that difficulty between optimism, pessimism, realism, all those things to help the patient?
I think it's extremely difficult. And we talked about before just being an undergrad or an old fart like me. I mean, it's still difficult, and it probably takes that you definitely need to feel confident about working with people in such severe pain as these people can be. And I also think we need to know the data to provide them with some arguments why we think prognosis should be either or, actually. So just providing that and feeling confident about talking about something that's not really that nice all the time. Hopefully that can also help the patient. And that's, of course, that's anecdotal. I don't have any data on that, but I think that over the years, at least I imagine that that's important.
And, you know, as you say, there isn't really the data as far as I'm aware. Again, it's kind of this, maybe a third of people have persistent problems, maybe, but there's a little bit of data from the Kiel group that suggests that people, stuff you would probably expect, people with worse pain, people with pain below the knee, people who are having trouble with their daily activities, they're more likely to have persistent pain. So nothing like too surprising there, right?
No.
So maybe to help guide you. And I think to my mind, it's just about maybe being just mentally agile or flexible. I wouldn't sort of condone people with acute sciatica being told you have, you know, X chance of having this for the rest of your life.
No, that would be stupid.
I think it's just like, if you're lucky enough to be in a kind of environment or service where you see someone for weeks or months, which is not a given actually, is it? If you're lucky enough to get to know that person, just being agile and flexible, you know, maybe they're coming to terms with it on their own, or are they still stuck in that life on hold? Do they need a little bit of help to come to an acceptance of the fact that this is taking longer than we hoped?
Yeah, because I think it starts to become difficult when things don't go as predicted, right?
Yeah,
so we see
a bit like life, really. Yeah.
What?
Bit like life, really.
Yeah. I guess you're right. So it seems like most of them, or a large amount of these, actually tend to those that starts to get better early seems to be pretty good after like 8-12 weeks. Do you agree on that? Yeah.
It fits with my impression.
Yeah. So that's always easy for them, but there's also some of the people we've seen when we're thinking, well, then they don't want to get surgery, and there's no hard neuro, so to speak. There's no real loss of power. We're not really worried. They've still got severe pain, but they're really keen on doing the conservative way. And then, like after 12 weeks, and it's only like small amount of disability that has changed, a small amount of pain, they might be getting 4 hours of sleep instead of just waking up every second hour and stuff like that. And that's where I think they're really struggling, these patients. It really becomes difficult for them, because they would also like, it's just taking too much time. It started to influence their life too much. They can't work full time, or they're scared of working full time. I mean, it really becomes very difficult at that time. Is that your experience as well, Tom?
Yeah, absolutely. And it's maybe one of the, I don't want to make out like radicular pain as some special fan, but it's maybe one of the highest responsibility things for your day-to-day physio. Like, assuming that, your average kind of new grad with a normal caseload, that's probably some of the biggest decisions that you have to make day to day. And I think a lot of it depends on what sort of environment you're in, what you do. So if you're in a service where referring to a surgeon is an absolute nightmare, and you can't do it directly, and it takes 2 months, and even then they only get to see, the triage, then it's very difficult, because you almost have to sort of preempt the referral. If you're lucky enough to work in a very integrated service, then obviously all this is much easier. And maybe you're listening to this podcast and thinking, what's the big fuss about? Because you can just ask someone down the corridor. So I think it's about kind of the environment also can often make it much more difficult too.
Yeah. So would you, if I understand some of the things you're saying now, is also the fact that what makes it somehow easier, not to say it's easy, but what makes it is to try to follow a patient, like from you see them in the beginning till they're like pain-free or back working or playing with their kids and stuff like that. I mean, such experience is probably very valuable. Instead of just seeing people when they're in most pain, or when they're having had symptoms for a year and not improving. So to some extent, experience also become important working with people in severe pain.
Absolutely, yeah. And with that experience, kind of looking at the other side of the coin, like because I know a lot of your listeners are kind of new grads or earlier in their career, aren't they? And we don't want to be too pessimistic. With the experience, you can also tell people from your own experience, I have seen people in your situation, and they got better, which is the other side of the coin. We need to be giving people that hope too. I was speaking to a physiotherapist who had sciatica, and she's experienced. She knows all the literature. She knows everything I know, but she said that even with all her knowledge, she needed to go and see another physio to tell her that repeatedly.
Yeah.
It was her sciatica kind of, again, typically she was complaining about the same thing. People telling her it was 6 to 8 weeks. It was more a matter of months.
Yeah.
She was fortunate, it went away, but she said she still needed to see the physio to test her neuro, for example, and say, hey, look, this is better than last time. Use whatever outcome measures and say, hey, this is better than last time. Because when you're in the trenches and you haven't slept and you can't think clearly and you're in pain and you got to get the kids off to school, I don't know, maybe you can speak to this, but I would imagine you start to kind of lose that hope and that optimism. So I think as well, like one of the roles of physio is not to do anything too fancy necessarily, but just to say, hey, you're 2 weeks better than you were. You're better than you were 2 weeks ago.
Yeah.
This, and this.
Yeah.
And so we're feeling good about this. You're getting slowly better, type of thing.
And I think that gives. I think you're totally right about that one. Despite that, we don't want to see them too often.
Yeah.
But I think you're right about that. Sometimes being objective. As well, which is very natural, that if we're in pain, we're not really always that good of seeing clarity or being objective. And there's also, coming back to, you said we don't have to do that much. We're just monitoring, changing plans slightly, providing hope and optimism that taking the next step is possible. But that's also one of the pitfalls. Then when it takes time. And we just briefly touched on this before, Tom, that when it takes time, there can be the pressure on the outside or the inside of the patient therapist connection that we need to do something.
Yep.
Despite the fact that when we're talking about radicular pain or radiculopathy for that matter, I think we're touching on that subject later on. We know that time is a very relevant issue. And that kind of, if we look at our profession, we tend to like to provide things for our patient, and I don't think we value how much we provide things just doing the basic things. Just by giving people hope or monitoring their neuro, stuff like that.
A guide or a custodian of the to give people a simple bit of reassurance that actually it's safe to go swimming. Don't worry, you're fine, and all those things we should count as big wins. That's what we're here for. And maybe a bit off topic, but I hope that emerges as the kind of thing that differentiates our profession from all the other similar professions, is that we're the best at just being the guide or the custodian. But to speak to the topic that you mentioned about the pressure to do something, I think what makes radicular pain a bit difficult again is that there are things to do which are pretty good. So things like injections and operations. It's almost become a bit, I'd hesitate to say it, but easier for low back pain. Because with the obvious exceptions, most people don't need an operation. And I don't know how things are where you are, but we have the guidelines in England to say that they don't. So I almost can't, even if I wanted to refer. So, and then similarly for injections and most medications. It's almost like that decision is taken off our plate, and we start to have the conversation. But in my mind, I'm not thinking with a patient with low back pain, maybe he needs a spinal fusion.
No,
because if I'm thinking that, it's not in the pathway anymore. With radicular pain, it's more difficult because, as your listeners probably know, and as you know, spinal kind of microdiscectomies are reasonably well evidence-based, and in England they're still approved in the guidelines, and so are injections, and so are anti-neuropathic medications. So that makes it a bit more difficult, is we don't want to do too much and faff about, but there are things we can do that can powerfully affect the patient's life for the better. So it's very difficult to know when to do those things, or at least when to refer for them.
You have to know when you need to refer for them. And that probably comes back to that there's so much talk in around our profession that we shouldn't operate on things. We should give conservative treatment, and in many ways, or in many subjects within our scope, it's very reasonable to look at it that way. And I think we've got more and more data. If we're looking at knee pain or hip pain, there's a lot of evidence that physical activity is a very, very good to promote instead. And we also see the spontaneous regression of what we're talking about today. But this, I still think there's a subgroup where it's important for us to try to differentiate. I said subgroup again. I did.
That's the Mark Laslett podcast.
I get confused all the time. That, or a subset, we could say that instead. It's just semantics, isn't it? That actually would benefit from surgery when you're having radicular pain. And the difficult thing is, despite having 15 years of practice, is when is it really time? When is it time? Is it always after 12 weeks? No, it's not. I mean, there's a drop of power. They haven't got it, but the bladder and bowel and sexual function is fine. But it's just power, or actually sometimes it's just too painful to be in that position of having radicular pain. There's no radiculopathy. It's just radicular pain. It's just so painful. I mean, sometimes we see surgery just based on that.
And I suppose we're lucky to have to not make the decision on the surgery. We only have to make the decision of, does this person need to see someone else to make the decision? So that's a bit easier, isn't it? I think as you say, the key things are loss of motor function, especially if it's progressive. And I think that's pretty accepted, right? Physio is reasonably well trained in that kind of sort of 3 out of 5 or less, in particular for the old foot drop, because that's going to seriously affect someone's life.
Yeah.
As you say, the pain, I think, is surgeon to surgeon, and whether they'll kind of do that. But again, luckily for most physios, we don't have to make that decision.
No.
I think probably the key thing for us, and the key kind of variable for us to look at, is the time. So in my experience, I think this will vary country to country, service to service, but in my experience, we might be a bit too slow to pull the trigger on that referral. And again, it's for well-meaning reasons, as you said. Like, we're rehab specialists, we don't want people to get surgery. But if someone is potentially not getting better, then all that time their nervous system is becoming progressively sensitized. The nerve itself is potentially becoming progressively damaged, so demyelinated, axon degeneration. We might not know that,
but there's a possibility of it.
There's a definite possibility. Yeah. And so there's probably one of those things where time is of the essence. And there's a good amount of data as well, or as good as it gets in this kind of domain, to say that people who get surgery earlier do better.
Yeah.
Forget what the exact, again, you can put it in your notes, but I believe it is about kind of 12 weeks is kind of the absolute where people tend to do best around that point. Doesn't mean that if you've gone past it, it's too late or anything, but the key message is that people who get surgery do better if they get it earlier.
Yeah.
And it makes perfect sense, right? What we know about the human body, nerves, if a nerve is compressed and pissed off and inflamed, then it's better to free it up. And there's certainly stories where you kind of wonder, if this person had just been referred a bit earlier, would they be okay now?
Yeah.
You do wonder sometimes.
And
so I think that's probably the key variable to think about, is not to just kind of let it drag on, not to think, well, we'll put you in the diary for a month and see if it's better then.
Yeah.
Especially if that referral is going to take time, it's probably to make it earlier.
And that's what I meant before, Tom. It's important to know how the lesion more or less behaves in the majority of patients. And if it doesn't behave within a certain way, again, more or less, we're not being too black and white here. It's important to recognize that physio doesn't seem to be appropriate, or there might be other ways of doing it. And I think that could probably be difficult to do that. I know it's been difficult for me to say, well, we're not successful. That's like saying I'm not successful. Well, the success here would definitely be more successful if we just got this patient on to the surgeon for an evaluation. I think so. And you're totally right. We can't know if there's demyelination, or what do you call it? Axon
degeneration.
Sorry, thank you.
All the kind of bad things that can happen. Yeah.
We can't know, but the doubt should definitely benefit the patient. We've also we say 12 weeks more or less in Denmark, of course, depending on the independent case in itself. But the 12th week, again, is not a cookbook. I mean, we shouldn't wait 12 weeks if we can hear them coming out in the hallway with their foot's dropping, right? Or if you say they report a progression. It really doesn't make, I mean, then our system should be so good that we should contact the GP or whatever the pathway is and say, okay, we need this referred on to a neurosurgeon to have an evaluation or an MRI. That's their decision. It's definitely getting worse.
Yeah. And I think, again, not wanting to complicate things a ton, but that's obviously hugely variable person to person. So I would imagine that in America, if anything, people are getting too many operations too quickly. I don't know, but that's my guess about how things are here. You've worked here.
Yeah, you're totally right. I mean, I've never seen that many fusions lumbar cervical fusions, as I saw
Yeah.
in 3 months in Texas.
Mm.
And the same goes for the injections. I mean, they came in on a Monday for a physio appointment,
Yeah.
but they came straight from the doctor. And I said,
Yeah.
where have you been before you came here? I came down from the doctor giving me a shot. And it went on like 4 weeks in a row sometimes. So it's getting
it's totally,
multiple
yeah.
treatments, right?
Yeah. So it's like, so it depends on the country and probably the service and the
Yeah.
person and things like that. But I think that, yeah, my impression is that in England, at least, the generally positive wave of anti-injection, anti-surgery bias has probably swept radicular pain along with it.
Yeah.
And there's also this kind of mental thing where, like the NICE guidelines, which are great, support them, but they say low back pain and radicular pain. It's this kind of thing where everything's lumped together. So I think sort of mentally people think of radicular pain as this sort of just like a really long low back pain that goes down your leg. But it's not. It does have these certain things that we should pick out.
Yeah. Yeah. But that's also mentioned in the triage process.
Mm-hmm.
Mm-hmm. We still group them as one when you read the guidelines. Is that what you're saying?
Yeah, I think it's yeah. I just think that and this is I'm on like thin ice because I'm making general sweeping statements.
Yeah.
I can only speak to my experience, which is it took me a good few months of practice to even realize and start getting pattern recognition for something called radicular pain.
Yeah.
It took me ages. So even like throughout my schooling and throughout all the reading that I'd done, for some reason, I never quite worked out that radicular pain is not just low back pain that goes down the leg.
Yeah.
And I might be making false generalizations, but my impression is that is kind of out there, that idea swimming around. And I'm not trying to say that it's a special, wonderful, unique condition, but I think it is important to pick out these little differences for patients' sake.
I think that's more or less generalization there. That would suit me as well.
Mm-hmm.
I would think that leg pain, okay, that's just always more or less referred pain.
Mm.
I would like go the opposite. Well, everything can just be fixed with physiotherapy. Nobody should get surgery. Mm-hmm. And I wouldn't like try. I don't know if I was naive or I was just dumb or not well read or something like that, but I wasn't really differentiating if it was radicular or referred pain. Mm. And when it comes to that, I think it's to me at least, it's pretty clear cut that we need to try to do that, because the referred pain, unless we experience or expecting something sinister or serious, we would never send those, or never, I shouldn't say that, it's physiotherapy, but we wouldn't send those for an MRI or a neurosurgeon evaluation, would we? We would only like more or less send those that had radiculopathy or radicular pain.
Yeah.
But that also comes back to, like, I talked to Mark about this, and I don't know if I ever stopped talking about this, being curious.
Yeah. Yeah.
Because I think it was Nikolai Bogduk who should be credited for the paper on the definition of pain, where they're trying to help us differentiate what is radicular pain, what is radiculopathy, what is referred pain. And of course it's difficult because lots of the time they coexist.
Mm-hmm. Mm-hmm. Yeah. Yeah. And yeah, I think, I mean, we could go through the definitions now if that's helpful.
Yeah,
Do you think
that'd be fine, Tom.
include it in the, as you say, the paper is Bogduk. I don't know how to pronounce his name.
Neither
I think it's 2009 anyway. He's like an OG low back pain guy. And
he's famous for a quote something like, "In God we trust. Everybody else bring your data."
So did he say that? Yeah. That sounds about right. But that's kind of the go-to paper for the definitions of these words, like referred pain, radicular pain, radiculopathy. Although the words have been around for a bit longer, I haven't actually been able to trace them back, but it seems that the words radicular pain and radiculopathy emerged in the last sort of few decades, maybe like mid-century. And then we have this fourth word, sciatica, which has been around forever.
Yeah.
That's in Shakespeare and stuff. But if we start with referred pain, first.
Yeah, let's do that.
Referred pain is not probably the most common referred pain that people know about, or everyone knows about from TV, is like the referred pain of a heart attack. So people, classically, on TV, it's like the shoulder and down the arm, but I hear it can pop up anywhere. But people don't feel the pain in their heart, type of thing. And there's lots of visceral referred pain. So if someone has left shoulder pain, that could be referred from the spleen, as you know, and all that stuff. And we get musculoskeletal referred pain as well. So let's see, often rotate, I seem to be sticking to the shoulder, but often rotate the cuff type pain. People often describe it sort of up here, down here, sort of halfway down the arm in my experience, or the insertion of deltoid, and sort of in the wrong place. And there's a lot of different sort of ideas about why this happens, but the main sort of classic one is the convergence projection model. So if you've got some sort of damage in your tissues, you're going to get some nociception, right? Some danger signals coming from the tissues. When those danger signals arrive at the spinal cord, they're also arriving with a bunch of other information, sort of incoming information, right? And it kind of gets jumbled up in the spinal cord. And when it's sent up to the brain, then the brain can't really parse what's coming from where. So that the explanation, sort of using that model, which is a little simplistic, but using that model, the explanation for referred low back pain into the leg would be, you've got a sprain in your facet joint or whatever, you're getting some danger messages coming into the spinal cord, but where those danger messages arrive in the spinal cord, you're also getting just messages from the leg just saying your leg's there, or it's moving, or it's hot, or it's cold, or whatever.
Yeah, it's me, the skin, I'm out there.
Yeah. Just general stuff, and all that gets jumbled up. When it arrives at the brain can't work out exactly where that facet joint is, right? We can't localize pain that well. So the brain gives you that experience of pain, and it gives you it kind of down the leg as well, because it's jumbled up all those messages.
It's a bit of an interpretation that basically is difficult for the system. So
it's kind of just localized it wrong. Or and that, sorry, go on.
No, and those patients, they would normally say something like, it feels deep, it's an ache, it's dull, or something like that, and they more or less wouldn't be able to tell where the pain is, that in a specific pattern. Is that correct? Is that
classically? Aching, gnawing, dull pain. As you say, like they can't particularly localize it well. They might gesture a little bit. It would tend to be not as bad as the back pain. So the back pain will be the worst pain, and then the referred pain will maybe diminish distally, and probably not necessarily, but possibly not have sensitivity in the nerves, like straight leg raise and stuff like that. That's a classic sort of referred pain down the leg.
Often conduct our neuro, and it would be termed normal, right?
It would, but just to be pedantic, obviously there's lots of false positives. As you know, I know you know this, but for the listeners, lots of false positives in the neurological exam. So someone has a knee replacement, they lose the reflex, patellar reflex, that sort of thing. But you wouldn't see any sort of marked neurological loss of function. So that's referred pain. And then you get these kind of two words, radicular pain and radiculopathy. And both those use this prefix radic, refers to the nerve root. So they both refer to what's going on at the nerve root. So where the cauda equina kind of hangs off the spinal cord ends, sort of L1, L2, and then all, So both, it refers to something going on there. Radiculopathy is not a pain term at all. If you're being really sort of pedantic and straight line about it, it's not a pain term. It just refers to loss of function because of a problem in the nerve root. So whether it's a disc herniation or sort of progressive stenosis, foraminal stenosis, whatever. Something stopped that nerve from conducting impulses up and down. Maybe it's that we can imagine there's kind of swelling, demyelination, that type of thing. So the nerve is not working as well as it should do. So the patient has weakness when you test them, numbness, light touch, pinprick, loss of reflex, and that's a radiculopathy. And it doesn't refer to the pain at all, just refers to loss of function.
Yeah.
But as we know, many radiculopathies are painful, but not all of them. Radicular pain is, as the name implies, refers to pain caused by something at the nerve root. So that phrase doesn't really have anything to do with the loss of function. It just says my nerve root is a problem and I've got pain usually down the leg. And we would probably use that phrase, again, it just refers to the pain. So it could be no loss of function, there could be loss of function. So we've got all these phrases kind of flying around, and there's not like an official only proper way to document. But what I would usually write is, if someone has sciatica, so nerve pain down the back of their leg, or the front or whatever, if someone has, I would write no loss of function, I would write radicular pain. If someone has loss of function and pain, I would write painful radiculopathy.
Yeah.
And for the very few patients who, for whatever reason, they have no pain, maybe they got better, but they still have lingering loss of function, I would write radiculopathy or painless radiculopathy or something.
Yeah.
I don't know if that's new to people, maybe they have to listen to that a couple of times.
I think I don't know why you're doing that, but my assumption would be that by doing that, you're implying or you're telling at least yourself what's the most important thing that I would like to monitor that's going on.
Mm-hmm.
And that could be important in relation to the thing we talked about before, when to refer on. So you could have those people with radicular or painful radiculopathy, as you said before, and then the pain subsides, and they start like the progression in the radiculopathy could actually increase, right?
Mm-hmm.
It could get worse. It could get more loss of function.
Yeah, theoretically, yeah. And I think I don't like to be too prescriptive or strict about words. Like, I think people get the knickers in a twist about it sometimes. Like, it doesn't matter that much, but I think it's important to know the concepts behind them.
Yeah.
And which, as you say, pertain to, the location of the problem, the loss of function, all these things. And one of the ways to learn the concepts is just to learn the words. Just read Bogduk's paper or listen back to what I just said for people who find it difficult.
Yeah.
And it starts everything, and then suddenly you have some categories to put stuff in it, and you kind of start to understand what's going on a bit.
Yeah. And then, of course, accept that it's very common that we see all three
Thank you.
Group together, right?
Yeah, absolutely. Yeah.
So we know that when we're testing, people come in with sciatica. You mentioned that word before. Mm-hmm. I don't even want to say the Danish word because I think it's too difficult to pronounce for you.
Go on.
Okay. But then you have to give it a go then.
Sure.
Yeah. It's called ischias.
Ischias.
Yeah. You actually did that very well. Yeah.
So is that from ischium?
Most likely. I haven't gone back in history like you did.
Sometimes it's called ischialgia.
Yeah.
Yeah. So when you do a literature search, you have to search for ischialgia as well. Yeah.
Okay. So yeah, that's the way we say it, and we I think we can agree on. We don't really have we can't always say, well, it's definitely a lumbar herniated disc that's causing this problem. But do you think it would be fair to say, like, based on I'm a bit going back to the triage and I'm going a bit back to prevalence, that like based on that, I would assume that most radicular pain, it's not very common and it's caused by sinister pathology.
Mm-hmm.
So when the patient like kind of puts us up against the corner and forces us to tell what we think it is, it would be I know the critics would say we can't say that, and I tend to agree. We can't say that. We need an MRI to see if it matches. But the likelihood of being something else than a herniated disc, I mean, it's really not that common. Would you agree on that, or am I be like again too strict, Tom?
I think I'd agree with you. I think if you know, yeah. If the patient has what you think of a classic radicular pain symptoms, which we mentioned the pain, but also descriptors like shooting or electric shock, pins and needles, descriptors of odd symptoms like running water, hotness, usually coldness rather than hotness. If someone's describing all those symptoms, if you have no other reason to think that it's anything else, especially if they describe a sudden onset or a slow build-up with a sudden onset, then you can say with some degree of probability, and I think Mark Laslett would agree with me, positive straight leg raise, throw that in the mix, that they have some sort of lesion in their disc herniation that's causing their pain. And then, as you say, the other side, the counter argument would be that you don't know that, so you shouldn't be saying that. And I can understand that, because from an ethical point of view, the worst thing to do is to lie to patients, and overconfidence is a form of lying. And
yeah, it is.
But I also think that any time we're reasoning, even when you cross the road, you're dealing with probabilities and making a judgment call based on probabilities. So if you're confident in your reasoning that there's a very high probability of someone having a disc herniation causing their sciatica, radicular pain, and you couch that in appropriate language, then I don't think there's any reason to like pussyfoot about it. Like, you can say that to someone. The other thing is that I was reading this really interesting article I'll send it on to you. It was like from the British Academy of Scientists, or someone very fancy and official sounding like that. And they did some research to find that lay people, when experts communicate to lay people with uncertainty, lay people actually trust them more, as long as they do it properly. So what that essentially means is that most lay people will trust a physio a bit more if you take the time to explain to them your reasoning and your degree of uncertainty. They'll see that as you being a sort of ethical, thoughtful professional, whereas quite naturally they have a less trust for people who pretend they have all the answers. So it's a very long answer to your question, but yeah, I would think so.
Yeah, but I think throwing in that paper is good, because we talked about it, especially we talked earlier about undergrads and not having the confidence and trying to put more things back in the toolbox and stuff like that, and not value, just give time and explain and stuff like that. But no, it's very fine, and the answer wasn't too long, Tom, not at all. So it kind of leads us a bit back in history. I know we flipped it around and we did things different than planned. Well, that's basically my life, I guess. So about what does history tell us about this? When did we start noticing that this could be caused by this material? Because the patient comes in the door when they've seen the GPs, like almost 50% of them would be saying, right, well, it's definitely my glutes that pinching my nerve.
I think I hope we don't talk about piriformis syndrome, because that should be another podcast. Is it coming?
I just sneaked it in. No, we're not talking about piriformis syndrome. But that's
the history of.
Are they saying that my piriformis or my glutes are pinching on my nerve? And we know what I've read, at least, that the majority of things wouldn't be coming from a pinched nerve in that buttock muscle.
Yeah. As you say, it's been known for a long time that pain down, classic sort of radicular pain, we keep saying back of the leg, But of course, it can be the front, and depending on the level of the herniation and just how the body's a bit weird like that. But classic sort of pain down the back of the leg, we've known for some time, is associated with the nerve, and people just tend to say sciatic nerve. And that's kind of going back to the 18th century. A guy called Domenico Cotugno or something postulated this, and for a long time the disease was named after him. It's surprisingly sort of recent that we started to localize the source of the problem to the spinal canal. So that you're getting onto like 1920s. You've got this surgeon called Putti. I can't remember his first name, but an American surgeon. And he starts to kind of start to theorize about, well, maybe the problems that we see on cadavers might cause nerve pain in the leg. And in some, during an operation that he was performing, he also found some disc material, which he didn't realize at the time was disc material. He just thought it was kind of this white gunk. He couldn't quite work out where it had come from. He thought it was probably from the disc. But that's always interesting to me, kind of how recent. So in the 1920s, people were still finding disc material in the spinal canal and not really knowing what it was or how it got there.
Yeah.
It's amazing, considering probably your average Joe on the street could probably talk you through a disc herniation now. Yeah. It comes to like the late 1930s that you've got a couple of surgeons, Mixter and Barr in America again, and they do the first or publish the first paper which like demonstrates that disc herniations can cause radicular pain. So they're kind of credited as sort of the leading lights in the history of the condition, really, because they're the first people who drew that parallel. And I think actually pretty soon after that, people started doing decompression operations. So you see a lot of that in the literature from kind of the 1940s and 50s. It was still kind of an open question of how the pain was caused. So I think there was kind of this idea that it was compression. It sort of intuitively makes sense that if you press on something, it will hurt. But it wasn't until the 50s, I think I'm going to say like 58, that people started to work out in a bit more detail. There's a paper by Smith and Wright, which I like to talk about, where they, I think a couple of surgeons, or one was a surgeon, and they had a cohort of patients with radicular pain, and they were all getting decompression surgeries. So what they did was, during the operation, during the decompression, they would tie I want to say nylon thread around the patient's nerve root. So you kind of loop it round, and take the two loose ends and pull it out. And then when they kind of stitched up the patient, they would leave those two loose ends hanging.
Yeah, I think I've actually heard about that before. Yeah, I think Buckduck mentioned it in his paper as well.
Mark did.
No, Buckduck. I think he mentioned.
Oh, Buckduck. That's probably how I found it. Yeah.
Yeah.
Well, David Poulter mentions it a lot as well. But they left this kind of cord hanging or string hanging around the nerve root. So give it a couple of days. Patient, kind of comes round. Give them a day to recover. Pain is gone or much better, because it's a pretty good operation for a lot of people. And then they would go and get the bit of nylon string that was hanging out the back of the patient and give it a tug. So they give it a tug, and as they tugged, it would also tug the nerve root.
Yeah.
And the patients would respond, would tell them, or usually, I guess, scream out in pain, tell them, that is my pain. That's the exact pain that I had before you gave me that operation.
Yeah.
So that's pretty interesting in itself, that kind of you can reproduce the pain. But there was a few more interesting things that came out of that. One was that they would say, tie the nylon cord. I keep saying it's nylon. I don't know where I got that from. Tie the cord.
It's a fish cord. It doesn't matter. It just makes the story better, Tom. Just put some more on top of it.
They would tie the floss round the nerve root, a level above, or say on the other side, essentially like as a control.
Yeah.
And then when they tugged on that, the patients might report a bit of dullness or something, but they basically wouldn't report the same symptoms. So that was evidence, really impressive evidence, that compression or tugging alone does not cause nerve root pain. The nerve root has to be already pissed off. It has to be already sensitized by something. It has to be already injured, whatever word you want to give it. And the compression alone is not sufficient. Interestingly, one of the other things that they found in that study is that the location of the pain in some patients would depend on how hard they were tugging. And we are coming back to piriformis syndrome now, because they found if you give it a gentle tug, then the patient will get just buttock pain. And then if you tug harder, then the pain will progressively travel distally, so down to the shin or the calf or whatever. And that sort of fits clinically with what we hear about sciatica as well. Like in my experience, a lot of patients say, I had a niggling pain in my buttock for a few weeks, and then all of a sudden it kicked off.
Yeah.
So there's some kind of, it demonstrates to me something interesting, which is that you can just feel sciatica in your buttock. So that was kind of the first paper to say, well, there's something missing. It's not just compression. And then you look into sort of the 80s and 90s for people to start working out things like neural inflammation, so that nerves, have this process of inflammation in themselves. The inflammation can be caused by prolonged compression. So if you compress a nerve for long enough, then it doesn't get the right blood flow, and it can start to have kind of an inflammatory reaction. But also, or possibly more commonly, by the disc material itself. So the disc material is pro-inflammatory, and they test this in like rats and stuff. So they'll get a bit of disc material and put it on a rat's nerve, and the nerve will become inflamed and sore.
Yeah.
So they're starting to put together the pieces that it also needs to be a pissed off nerve in order to hurt. And then more recently, a lot of interesting stuff about neuroinflammation I don't quite understand, except that it can spread. So it can spread to sort of the spinal cord itself, which is a sort of mechanism for sensitizing other incoming streams of afferent information.
I think Anina Schmidt would probably be able to tell us a lot about that.
Yeah. She get her on.
Yeah. And it goes pretty fast sometimes.
Yeah.
Sometimes I have to hear that podcast like more than once.
Yeah.
So Tom, that basically leaves us, now we have an understanding about what could cause the pain. We have an understanding about different aspects, how it presents itself. We've talked about the prognosis and how it should be. And the fact that sometimes maybe we shouldn't hesitate that much to get a second opinion on this, and not just put it in a group with back pain. But what we also talked about before starting and getting on with this, we talked about the management of this, and it's something else than just surgery or injection, or actually time, which is an important issue in this as well, as long as it's not getting progressively worse. And we also agreed on there wasn't really anything that seemed to be better than anything else out there. It's probably. Do you agree on that?
Certainly, if you, probably, yeah.
Yeah, and what I mean is the fact that there's no cookbook that tells us if you get people in with this problem, you should definitely do that and that. It's still just based on guidelines.
Yeah.
But there's probably a lot of things you shouldn't do because you piss off the nerve even more.
Mm-hmm.
And one of the things I see in clinic is the fact that people come into the door, they've been told to sit up straight or do lying push-ups. And when you ask them what happens, they say it irritates their nerve.
Yeah.
So we probably the patient is probably better off if we're listening to their symptoms more than if we're predefined on what we want to give them.
Mm-hmm.
Do you agree on that?
Yeah, absolutely. Yeah. I think, you don't want to kind of just pick out the worst examples or pick on anything too much, but I think certainly that reflex that often it's not the physiotherapist, it's just the patient has done the right thing and they've decided to sit up straight all the time or
Yeah.
whatever. Sometimes people think it's the hamstrings, so they stretch the hamstrings and just piss it off a lot more. When, as you say, it all comes back to listening to the symptoms. I actually, and in that sense, there's probably the condition is not too different or unique at all. I actually had a really interesting conversation with another, as I mentioned her earlier, physiotherapist who had sciatica, but she's also a pretty high-level triathlete, just like really sort of fit into her kind of athletics and stuff. And she described it, the whole process as, not pissing things off too much, but also not giving it too much of a rest. So every time she went for a run, she would kind of, being a triathlete, she wasn't used to kind of working out how much she could do, and she'd time herself anyway. So she'd know how much she could do, and she did 1 minute one day, she'd do 1 minute and 10 seconds the next day. If she ever pissed it off too much, she would just come down and go back up again. Same with her sliders and gliders. So she would find what she could do. Oh, I can put my head here. I'll do it here for a bit. Now I'll try and put my head here. If it's too much, come back. And look, this is no great secret. This is how athletes train. It's just kind of slowly pushing and pushing. If you push too hard, take a rest. That's why she was so good at it.
Yeah.
And probably the best advocate of that, from a physiotherapy point of view, is Greg Lehman. Like, she used the phrase herself, like poking the bear.
Yeah.
So I think certainly from that point of view, to answer your question, there's probably no like one super approach that's better than others. It's just finding the tolerance, yes, for the nerve, but also that person's tolerance for activity and trying to increase it. Maybe you could make a case that with nerve pain, you need to be a bit more careful, because if you piss it off, you really piss it off.
Yeah.
People can be really miserable. There's certainly a case to be made for that.
But I also think, Tom, that comes back to, again, being the most important thing, is because that, of course, varies between the patients. But it is the fact that that we educate people well. Mm-hmm. And they make decisions based on information that is relevant for the problem. Because not all patient comes in, or at least not comes in my door, and are able to, like, every day find out how much can I push it and how much should I slow down. I mean, we need to be patient when we're explaining this to our clients and our patient or the human with this. And I think we should accept it being a process, and we need to, like, kind of more or less sell it as a process. It's a learning curve. We need to figure out how is it going to be over the next 2 weeks, of course, with daily variation. So with that comes the message that we despite being able to, like, navigate on a daily basis, we also need to tell them at the same time you should look forward, try to stay objective, like 1 or 2 or 3 weeks at a time, which makes it quite difficult sometimes for them, I guess.
Especially with the thing that we were talking about before, which is that, a lot of people don't get better. So you kind of got that in the background as well. Yeah. And that's not their fault. It doesn't mean they've done it wrong. There's lots of reasons we don't understand why that doesn't happen for some people. So that's kind of the complicating factor. Certainly, yeah.
Yeah.
But sorry.
I think what I tend to do when I see a patient like this, and I've done during my exam, I always try to see if I can give them something that gives them relief, and gives them something. It could sound wrong, but it could be anything from maybe an exercise. You said a slider or a glider. It could be looking for a directional preference. It could be a position of lying down that kinds of takes some of the irritation of the symptoms off. I mean, it's really not, that's what I mean. There's nothing, there might be something that's bad, but we don't have the data to say we always have to do that and that. So I think we just need to step up the path sometimes and say, well, we say that they shouldn't rest. That's bad for back pain. Well, a lot of people with sciatica actually think it's nice.
Yeah.
And then again, we should find out when it's not appropriate to do anymore.
Yeah.
Or when it's not appropriate to keep doing those floppy push-ups and maybe start flexing people instead. Or whatever we tend to do.
Yeah. I think a few things I can only sort of agree with what you're saying, and to kind of work out, it can even be part of the assessment, can't it? Like often you don't need to do that kind of movement assessment, but you can turn it into a type of treatment, and often the patient will have been too scared or just too busy to work out those things for themselves, and help them to understand, why this position hurts, because you're stretching your nerve at this bit, so that they kind of get the picture in your mind that you have in yours. And I'm certainly quite guilty of that. I think as physiotherapists, we forget how kinesio aware we are. Like, we're all sports people. We're thinking about bodies all the time. Well, sport-ish. And
what do you mean by that?
A lot of people don't have that awareness. You need to coach them through it a little bit.
Yeah. Do you think that sometimes we're not being aggressive enough in the process of getting people better? And we tend to stick to the safe area. Well, they don't get more pain when they're lying down doing this exercise, but we're really not engaging on the target or the goals, which is back to running, work, or maybe they're scared of working. So we're trying to avoid that confrontation. Because I sometimes think that sometimes I really burn my fingers because I'm quite aggressive at points with people like this. And I think I've learned over the years that in the beginning I was too little aggressive, not being targeting their goals enough, being too much in the safe. And then I've had a period of my time where I was like, well, just give it a go and let's see what happens. And I see it varies a lot, but when I see people for maybe a second eval or something like that, and look at their history, they've sometimes been treated too carefully, like they're too fragile.
Yeah, I think I've had similar sort of experiences, and the natural thing to do is, for most people, as is well known now, is to be avoidant of pain and kinesiophobic and things. And I think the message is definitely getting out there that that's not very helpful, and that your own fear of the patient's pain can be quite bad for them. And then, as you say, there's kind of the other direction. So I can think of a few huge mistakes I've made with people with sciatica, where I've done exposure therapy. So I've just really encouraged them to just go for it, even though it hurt. I think I'm a bit, very embarrassed to say that. And, I can't, it seems to not to help them at all. And so there is that kind of the boring answer, like the happy middle ground.
Yeah.
I mean, I sometimes think of helpful and unhelpful avoidance. So helpful avoidance and unhelpful avoidance. Is the fact that this person really doesn't like putting their shoes on, is that helpful or unhelpful? Well, if their pain came on like last week and they've been given 2 weeks off work, maybe that's helpful for now, because it's just going to make them miserable if they try it. And theoretically, it might be nice just to give the nerve a break and give the central nervous system a break from all that afferent input. But if they are 2 months in and they still don't like putting their shoes on, and they go into work in flip-flops or whatever, then you can call it an unhelpful avoidance. And I think one of the things that makes me a little bit, there's the anxiety, especially with nerves. Like, I still have this like innate fear of hurting a nerve. But my understanding of the animal research is that there's quite a lot of evidence to show that after they injure, essentially that's what they do, they take rats and they injure the sciatic nerves, or mice injure the sciatic nerves to test, and they put them to work like a day or two after, and their pain and their nerve doesn't get worse or more damaged. So in animals, at least, their nerves, even when they're injured and hurt, they can still withstand a reasonable amount of exercise and activity. And I think that message is out there with muscles now, right? So there's like this idea that you can do early rehab on a hamstring strain, even if it's painful. I suspect that the animal research, maybe you do need to get Anina on, but I think that supports it from what I've seen. And having spoken to her about this as well, is that same for nerves. It's not the end of the world if you do too much. It just makes you miserable.
Yeah, yeah. For some days or maybe a week. Yeah, yeah. And then it settles back. Yeah. And that comes back to this, is still based on symptoms then.
I think it is based on symptoms, yeah, with that safety net that, what are we trying to say? I suppose we're trying to say two opposite things, which is nerves are, you need to be a bit more careful, but also you don't need to be too careful.
Yeah, and that's what I mean. I mean, we shouldn't have like pre-made programs, because people are individuals, and they would, I think most people would like respond on their symptoms. That would tell them if they're doing it too much or too little. And then they would need the discussion about, is that really too much or is that really too little? Yeah. Yeah. Are you okay with that?
I'm happy with that.
You're happy with that. So yeah, we don't want me putting words in your mouth.
I'm just thinking about any sort of, I always feel like these messages might be a bit disappointing to new grads.
Yeah.
But if we think it's true, and I think it's true.
Or at the moment, it's probably something that seems to be a fair place, like to stand and work out from that until we know more.
Isn't it funny? Our discussion has become like a lot more. We're both having a lot more trouble now. We're talking about treatment from a physiotherapy perspective.
Yeah.
I think well, I speak for myself. It's much easier to kind of hold court and talk about, the history or whatever, or talk about the pathophysiology. But when you get into the actual nuts and bolts, bread and butter treatment from a physiotherapy perspective, it gets much more difficult, and you find yourself like second guessing yourself or qualifying everything you're saying.
Yeah. It could sound more vague. I totally agree on that. But then again, it wasn't me that made the quote, but it's okay to be uncertain, I guess.
Yeah.
And I think we're better off by that. And I think the literature you brought in before kind of says that it's better to be a bit uncertain than being too certain. And I think there's hope for progress then, Tom, if we're not too certain or caught up in a special idea of doing things.
Yeah. And I would say and I keep mentioning kind of new grads, because you mentioned off mic that was one particular group of people who you wanted to like have this podcast for. And I would say that I'm maybe a good case study, because I've a relatively short career, but I've know quite a lot about one thing, radicular pain, just because it's interesting and people ask me to do stuff like this for some reason. But I know almost nothing about. Sorry?
Because it's interesting.
Yeah.
Yeah.
I know almost nothing about other stuff like ACL rehab, like feet in general. No idea. And my kind of message of encouragement to anyone listening, like new grads, is that the more you learn and the more you think about something and the more you engage with a subject, even if it doesn't actually change what you do on the surface, that comes across in your interaction with patients. So that thing we were talking about of the gray areas and just balancing this and that, it's kind of vague and it applies to everything. But if I do that with radicular pain patients, I get so much more success, and patients are so much happier because they can feel that I know about the topic. I can give them these little tips based on stuff that they say and stuff. So you put in all this work and it really does pay off. It's just hard to explain how.
Yeah.
But I know that because if I have an ACL patient or someone with any kind of foot pain, I'm absolutely crap. They know instantly that I can't remember which one is the talus, you know? So it really does help, and it does give you this sense of like doing the right thing to keep learning about these things.
Yeah. So interest is important. What other advice would you give new grads?
Ooh.
Coming out, just doesn't matter if it's secondary, tertiary, or primary sector. I know it's a difficult one. It's actually a bit tricky to like just present it for you like this.
No. I would say, let's see. It's more that I have too much advice. I'm trying to think of something interesting. So the usual things people say, they're all true. You know, listen to your patient. They have the answers. That's true. But everyone's going to say that.
You want to be special, won't you?
It's not going to be very special, but I would say to read widely and read outside your bubble, and maybe as a precondition for that, to know what the bubble is.
Yeah.
To kind of quite deliberately try to find perspectives outside. So I know you already on the podcast, you've had people who would disagree if you had them on together. So I think to read historical literature as well, because it's kind of quite humbling to find out that everything I've said today, Louis Gifford wrote it 20 years ago, for example. Yeah. It's like it's nothing new.
I think you're very right about that, Tom. Like being humble about the history. Yeah.
So read back in time, read laterally into other kind of parts of physio, read fiction books so you can understand what it's like to be a human being. It's really important. It's true.
Yeah.
So I'd just say keep reading. How's that?
That's just very special. Nobody else said that. No, it's great. And I think you kind of need to know what your bubble is to look out. But the thing is that both looking laterally and back in time, I think that gives you the opportunity to actually make some arguments and reason. And also, you said we were being vague. Well, I agree on that, but that's okay to be vague, and you can only be vague if you can actually, or me being vague. I think it's done based on the fact that I've read a few things, so I know I can't be certain. And having respect about that, I think that's so important. There was somebody before us, as you said, Gifford said this 20 years ago. I mean, he's still referenced a lot of time, right? So there's somebody else out there.
Yeah.
Tom, where can people find out more about you?
So I'm most active on Twitter at Thomas_Jesson. If you want to read stuff I've written in the past, I've written a little bit about pain, posture, that type of thing. My website is tomjesson.com. And at the moment, I'm putting most of my effort into a newsletter. So at the moment, it's like monthly, but I'm trying to make it weekly about sciatica. Just kind of trying to keep saying interesting things about sciatica.
Yeah.
And tomjesson.substack.com. But as I say, probably at Thomas_Jesson on Twitter, and then just kind of go from there. If you're interested.
We'll put it in the show notes because I get your newsletters.
Yeah.
And actually read them. Yeah, or at least some of it. No.
Well, they're so long. I'm going to split them up into like one a week now, basically.
Yeah.
We're essentially like little mini books.
Yeah.
Far too much, you know.
I can't remember if it was this one or the last one about basically the anatomy.
Yeah.
That was a long one.
Yeah.
I did split it up. I did. I didn't take it in just one turn. I had to admit that.
Yeah. Yeah. I think there's so much. It's crazy. There's so much CPD out there at the moment.
Yeah.
Yeah.
Yeah. Well, Tom, it's been an absolute pleasure and an honor to have spoken with you. And
Thank
I
you.
think we've covered some good ground here, which is important both for undergrad, but also people like me that's been doing this for quite a few times now. Yeah, I haven't thought about the thing about it lasted 50 years. I haven't compared that to my experience. Yeah, it's more than three times as much as I. Oh, it's quite a long time. Yeah.
Yeah, pretty impressive.
Yeah. Well, thanks, Tom.
Thanks, Brian. I really enjoyed it. Thank you.
I'm glad you did that.